Welcome to This Explainer. Today, we're diving deep, and I mean really rigorously unpacking the critical nuances of non-opioid pain management. We are going to clarify these clinical guidelines so thoroughly that you'll walk away with an intuitive grasp of every single concept without ever needing to flip through a dense textbook. Let's get right into it.
Here is our agenda for today. We'll start with general analgesic principles, move into specific pain treatments, cover acetaminophen dosing and its risks, break down the 9 key characteristics of NSAIDs, look at their specific dosing profiles, and finally, wrap up with the strict details of ketorolac dosing.
All right, Section 1, Analgesics and their general principles. So, if you look at our clinical toolkit, it essentially breaks down into 3 distinct categories. First, we have our non-opioids for baseline relief. This is your standard aspirin, ibuprofen, and acetaminophen. Then we step up to opioids for the heavier lifting, which includes agonists, partial and mixed varieties. And finally, we utilize adjuvants. Now, while these aren't strictly pain meds, drugs like tricyclic antidepressants, anti-seizure medications, or even caffeine and corticosteroids act as incredible physiological assistants to those primary drugs. They really help round out the treatment.
Now, here is the golden rule, especially when we're dealing with cancer pain. Early use of adequate analgesic levels is absolutely key. Strictly scheduling those doses rather than waiting for the pain to strike, which is known as PRN or as-needed dosing, is completely paramount here. You literally have to stay ahead of the pain cascade to prevent it from ramping up. And of course, you must always ensure a rescue medication is readily available for any breakthrough agony.
Moving right along to Section 2, Specific Pain Treatments.
This is where things get really fascinating. You see, matching the drug to the exact pathology of the pain is absolutely crucial. For instance, visceral or deafferentation nerve pain requires agents like tricyclic antidepressants or tryptophan. And if that nerve pain is paroxysmal, meaning it's sudden and lancinating, carbamazepine is going to be your go-to. On the flip side, pain from metastatic bone disease responds uniquely well to steroids, aspirin, and NSAIDs. Why? Because these drugs specifically block the prostaglandin-mediated sensitization of A delta and C nerve fibers. It's a completely different mechanism tailored for completely different kind of pain.
Let's pivot to Section 3, acetaminophen dosing and its specific risks. Okay, let's look at the numbers. For adults, the standard dose is 650 to 1,000 milligrams every 4 to 6 hours, and that has a hard, non-negotiable daily maximum of 4,000 milligrams. Now, for pediatrics, we have to get into very precise weight-based calculations. Infants require 10 to 15 milligrams per kilogram every 4 to 6 hours. For older children, the calculation is 1 grain per year of age, up to 650 milligrams, capping at a maximum single dose of 15 milligrams per kilogram every 4 hours. You've got to calculate these pediatric doses meticulously. We have to talk about hepatic or liver toxicity. Typically, getting liver toxicity from acetaminophen requires a massive dose, like over 10 grams a day. However, and this is a huge however, a fasting patient, a chronic alcoholic, or someone taking cytochrome P450 enzyme-inducing drugs can suffer severe, life-threatening liver damage at doses well below that standard 4,000 milligram limit. So you always have to look at the whole patient, right? Not just the drug itself.
All right, Section 4, NSAIDs, specifically breaking down their 9 key characteristics.
Let's start with characteristics 1 through 3. At their core, NSAIDs work by inhibiting the cyclooxygenase or COX enzyme, which effectively stops the synthesis of prostaglandins and thromboxanes in their tracks. Almost all of them are administered orally, with the notable exception of ketorolac. What makes them so incredibly valuable clinically is that they cause zero physiological dependence, and even better, they have a highly beneficial additive effect. This means they stack their pain relief perfectly alongside opioid analgesics, giving your patient a really superior multimodal coverage.
But there's a catch, and that's characteristic 4, the ceiling effect. These drugs have a hard biological limit, usually between 650 and 1,300 milligrams for aspirin or acetaminophen. Pushing past that specific dose won't give your patient a single drop more of pain relief, literally none. It will only invite dangerous side effects.
Characteristics 5 and 6 deal with the gut. While these drugs provide great relief, we have to manage the well-known risk of GI ulceration and hemorrhage. To protect the stomach lining, we'll sometimes prescribe misoprostol alongside the NSAID. But listen closely, because this comes with a severe warning. Misoprostol is a prostaglandin that acts as an abortifacient. It is absolutely, strictly contraindicated in pregnant women or women of childbearing potential. No exceptions.
Characteristic 7 is all about platelet function. NSAIDs generally inhibit platelet function and prolong bleeding times. But aspirin? Aspirin is a completely unique beast here. It irreversibly binds to the COX enzyme. That means it permanently disables the platelet's function for its entire 8 to 10-day lifespan. Basically, that platelet is broken until the body manufactures a brand new one.
Wrapping up with characteristics 8 and 9, which covers some pretty severe systemic risks that require your constant vigilance. NSAIDs cause sodium and water retention by reducing the synthesis of renal vasodilator prostaglandins. This reduces blood flow to the kidneys, inviting nephrotoxicity, interstitial nephritis, and hyperkalemia. Plus, non-aspirin NSAIDs uniquely elevate the cardiovascular risk for heart attacks and strokes, so careful patient selection is a must.
Next up, Section 5. NSAID dosing profiles. The golden rule here? Always use the lowest effective dose. Let's look at a few. Aspirin caps at 4,000 milligrams a day. Diclofenac has a much tighter window. You start at 25 milligrams and max out at just 200 milligrams daily. Naproxen requires a loading dose of 500 milligrams before dropping to 250 every 6 to 8 hours, and you've got to keep that daily max strictly under 1250. Then there's Nubumetone, which maxes at 2,000 milligrams a day. And interestingly, it doesn't actually interfere with platelet function like most of the other NSAIDs do.
We definitely can't skip this critical caution regarding pediatric dosing. When you're using the 100 milligram per milliliter suspension of ibuprofen for kids between 6 months and 12 years old, the dose is 5 to 10 milligrams per kilogram, and it absolutely maxes out at 40 milligrams per kilo daily. And remember, you must never, ever use aspirin for children due to the terrifying risk of them developing Ray's syndrome.
Finally, Section 6, Ketorolac, details and dosing.
So, Ketorolac, commonly known as Toradol, is truly special because it's the only parenteral, meaning IV and IM, NSAID approved in the US. It's your absolute drug of choice when you desperately need pain control but just cannot risk the side effects of narcotics. You use it to avoid sedation and respiratory depression, or when the patient can't tolerate severe constipation, or if they get extremely nauseated by narcotics, or if there are dependency concerns. It's also fantastic for safely supplementing epidural morphine without compounding any respiratory risk.
But because it is so incredibly potent, parenteral ketorolac has a strict, non-negotiable maximum of 120 milligrams per day. And here is the most critical rule for this drug. Use must never exceed 5 days. Honestly, keeping it to 3 days is a much safer guideline. If you prolong it, the risk for profound bleeding and severe GI erosion simply skyrockets. Also, those oral 10 milligram tablets, they are strictly for continuing an already established IV or IM therapy. They are never to be used as a standalone routine NSAID.
To make things even more precise, we often have to adjust that Toradol dose for our vulnerable patients. If your patient is under 50 kilograms, over 65 years old, or has poor kidney function, you must have their dose immediately. To determine that kidney function, we use the Cockcroft-Gault equation to calculate creatinine clearance. It sounds complicated, but it's just math. You take 140 minus their age, multiply that by their ideal body weight, divide the whole thing by 72 times their serum creatinine, and then multiply by 0.85 if the patient is female. If that final number is less than 50 milliliters per minute, you cut that ketorolac dose right in half.
So, we've covered the physiological mechanisms, the hard limits, and the exact formulas, leaving us with this ultimate clinical question to ponder. With tools as powerful as Ketorolac and as ubiquitous as acetaminophen in your arsenal, how will you balance the aggressive pursuit of pain relief against the severe, unseen limits of your patient's vital organs? It's a delicate, everyday math, and getting it exactly right is what makes a truly exceptional clinician. Thanks for joining me on this explainer.